So, I am Dr. Jillian Goddard. I'm an endocrinologist and the author of the Savvy Patient newsletter here on Substack. Um, Welcome to our February Ask Me Anything. Um, I had a number of different questions sent in from a number of you ahead of time, which I'm always happy to get those emails. But if anybody has any questions they want me to answer right now, you can put them in the chat and we will get to as many questions as we can over the next little while. Um, so I'm going to start by answering some questions. A bunch of you were asking about some shortages that you're experiencing related to your estrogen patches. So in the last few weeks, maybe the last month or so, many people have been told by their pharmacy that they're experiencing shortages of different estradiol patches. Um, these shortages are affecting, well, let's take a step back. The estradiol patch is generic. And there are a number of different manufacturers that make generic estradiol patches. Several of the manufacturers are experiencing some shortages in some different doses. The dose that seems to be the most affected among the different manufacturers is the 0.05 milligram per day dose of the twice weekly patch. That is probably because that is like the most middle of the road dose, and so it is probably the dose that the most people are on. And so that makes sense that there would be shortages in that dose more. What's driving this is really just an increase in demand. For 20 years, manufacturers didn't need to produce a lot of estrogen patches because not a lot of people were using hormone therapy. And we had no issues. Now more and more women are feeling comfortable using estrogen patches to treat their perimenopausal symptoms. And so there's an increased demand, and the manufacturers need to ramp up their ability to produce more patches. It's not that easy to bring new factories online to manufacture drugs. When you start manufacturing a new drug at a new factory, you actually have to bring the FDA in. They have to sample your new drug and make sure that the quality control is good. And so it can take some time to bring new manufacturing facilities online. The other thing is that many of the generic manufacturers are overseas. There's a lot of generic manufacturers in India, and there's a lot of generic manufacturers in Europe. And so it's also a matter of not just making more, but getting more estrogen patches into the US. So if your estrogen patch is backordered or you've been told that there's a shortage, what can you do about it? You can do a couple of different things. The first thing I would say is check around to different pharmacies because not all pharmacies use the same wholesalers, and different wholesalers work with different manufacturers. I find that oftentimes when there's shortages, CVS is actually the worst at getting medications. They work with a single wholesaler, and they often have more limited ability to switch from one generic formulation to another. So check around with different pharmacies. Mom and pop pharmacies actually can be really great in this situation because they often work with multiple wholesalers, and those wholesalers work with a lot of different generic manufacturers. And so that can be a good way to find what you're looking for. You can switch formulations. So like I said, the one that seems to be the biggest problem is the 0.05 dose in the twice weekly patch. So the patch you change twice a week. If there's a once weekly patch, you may be able to change to that. There's and there's sort of a number of other forms. You could try either an equivalent dose of an oral if that's something that's safe for you, so you don't have any cardiovascular history or and then you can also try Divigel. Divigel's a gel instead of a patch. You do have to put it on daily, but the dosing is very similar to it's estradiol, transdermal estradiol, and so it's very, very similar to the estrogen patch. So if you really can't get the patch in a dose that works for you, you can try that. The other option, because the 0.05 dose is the one that's hardest to get, would be to talk to your doctor about whether going down a dose to the 0.0375 or up a dose to the 0.075 would be appropriate for you. And that may help you navigate that as well. It is unclear how long this is going to last. One of the manufacturers expects to have shortages through the end of 2026. So we could be dealing with this for quite a while. So just know that it may not be short-lived. One of the other manufacturers says that they're going to be ramping up production and meeting demand by the end of March. But others are showing that they're going to have some shortages in the end of March. So it's going to be a fluid situation until we can really get things ramped up. Good luck. Um, the second question I'm going to talk about today is actually related to this. So I had a question about someone who switched manufacturers. So she was getting one patch from, I think it was Novartis, and they switched her to a Mylan patch. So those are both generic manufacturers of estradiol. So she was on, 1.1 of estradiol in the Novartis patch and was given the Mylan patch instead because she got it at a different pharmacy. Um, and she said, "Am I just imagining it? I'm breaking out more. And I feel like it happened when I switched patches. Can this actually be because I switched from one manufacturer to the other? Or is it all just kind of in my head?" It can absolutely be because you switched from one manufacturer to the other. Um, when manufacturers are given the go ahead from the FDA to manufacture a generic medication, it can vary from the brand medication by a substantial amount, actually. So, a you can vary usually by as much as 20%. So you can imagine, so if you're on the what that means, if you're on the point 0.1 dose of estradiol, um, the patch could have as little as 0.08 or as much as like 0.12, um, or as much as sorry, as much as as much as um as much as 20% more, 20% less. So that for most drugs, that doesn't matter. So, like for your cholesterol medicine, it doesn't matter whether your 5 milligrams of Crestor is really 4 milligrams or 6 milligrams. That doesn't matter for that drug. But for hormones, it often does. Um, those small changes can really affect how people feel. In both directions. We see this a ton in thyroid issues. So switching from one generic to the other. A lot of times doctors tell people not to do that if they can help it because you can need to change dose. It can really affect the blood levels of the hormone that you're getting from the medication. Um, in this situation, If you're breaking out, I would sorry, excuse me. I would probably actually try, I mean, point 0.1 is actually the highest dose, but if you were on a lower dose and you were experiencing this, I would actually try going up on the dose from the new manufacturer because it probably has a little less in it. If you're getting like breast tenderness, or you could even see a little bit of vaginal bleeding, that's something you should address with your doctor. But you may need to go down a dose with the new manufacturer. Um, when you're not in a shortage, you can try and stay on the same generic manufacturer's medication all the time. But not, that doesn't, but in a shortage, it's really tricky to do that because you really want to try and just have the estrogen patch. Um, so yes, but if you're having symptoms, talk to your doctor because you might need a little bit of a dose adjustment when you've switched from one manufacturer to another manufacturer. That is in fact real. You are not imagining it. Um, a bunch of you wrote to ask about the new Wegovy pill. And so I thought we would talk a little bit about that because that is clearly something that is on many people's minds. The pill was approved in December, and it hit the market at the very beginning of January this year. And I think it's front of mind for many people because the commercials have been all over TV. Um, so what is the new Wegovy pill and like how is it different than the injections? Um, the new Wegovy pill is literally just semaglutide in pill form. So it is the same active drug, the same molecule that is in Ozempic and Wegovy injections. It's just in a pill form. It's actually not new. Um, Oral semaglutide was approved under the brand name Rybelsus back in 2019, I think, to treat type 2 diabetes. And so this idea of semaglutide in a pill is not new. Um, there's a lot of confusion about what this pill is for. I get served these ads all the time on social media. I'm getting served ads about, oh, lose those last 10 pounds effortlessly with the new Wegovy pill. The pill, the indications for using the pill are no different than the indications for using injectable Wegovy. The indications for using the Wegovy pill are no different than the indications for using injectable Wegovy. People see the same degree of weight loss with the Wegovy pill. It is intended to be used in the same settings, people with overweight or obesity, and in many cases, people have weight related comorbidities. So, pre-diabetes, high cholesterol, high blood pressure. Um, so the indication for using the pill is the same. It's the same drug. It's really just how it's getting into you. And the tricky thing about the Wegovy pill is the way they get the semaglutide to get into the bloodstream. So GLP-1s are peptides. They're very easily broken down in the stomach. And so getting a medication through the stomach and into the gut where most medications get absorbed is really difficult. Additionally, even when you get GLP-1 into your gut, it doesn't get well absorbed through the gut lining. And so that has been a big challenge, and that's why it took so long to come up with GLP-1 pills. The way the Wegovy pill works is it's bound to like a carrier molecule and it actually gets absorbed through the stomach lining. So it never needs to go past the stomach. The carrier molecule protects it from the acid in the stomach and allows it to be absorbed through the stomach lining. But what that means is you have to be really careful about how you take it. So the Wegovy pill has to be taken on a completely empty stomach. You don't even want liquid in your stomach. You want a completely empty stomach, and you want to take it with no more than 4 ounces of water. And that's because even increased liquid in the stomach can prevent the Wegovy from being absorbed. So many of my patients have been asking about switching. A few of them have, but a lot of them feel like because you have to be so careful about how you take the Wegovy pill, it's not really for them. It's easier for them to do a once a week injection. The Wegovy pill is also daily. Um, and so that's that. There is going to be a new GLP-1 pill coming. It's called orforglipron. There's not a brand name released yet. And that pill is coming from Eli Lilly. That one's totally different in its mechanism of action. Not in its mechanism of action, how the way it's formulated. So it is not so tirzepatide is Mounjaro and Zepbound. The new pill that's going to be coming out in April or around then is not tirzepatide in pill form. So it's different. The Wegovy pill is semaglutide in pill form. The new orforglipron is different. They actually created a whole new molecule, but it will act more similarly to tirzepatide in that it is a dual agonist. It will act on GLP-1 and GIP the way tirzepatide does, even though it's not the same molecule. The beauty of orforglipron is actually that it doesn't have any of the limitations that the Wegovy pill does as far as how you can take it. So if how you have to take the Wegovy pill is a limitation for you, if you wait a couple of months, there should be another oral option. But I think that the biggest confusion is sort of what the point of the pill is. And the point is just to give people options. It's not to change the indication for GLP-1s. It's just to give people more choices about how to take a GLP-1. And so I hope that's helpful. Welcome to those of you who are just joining. I'm Dr. Jillian Goddard, and I'm the author of the Savvy Patient Substack. And today I'm answering your questions. If anyone has a question they want me to answer today, go ahead and put it in the chat. And in the meantime, many of you sent questions in advance, and so we'll continue along with those. I got a great question from someone about hormone testing. And I think that this is a common question that people have. So the question was, does it ever make sense for a healthy woman to get to test their hormones to get a baseline? And I think that the reason that this is confusing to people is because there is this idea that there's a level of reproductive hormone and that everyone should have, and that deviations from that specific level may cause symptoms. Um, there's also this idea that when we give you hormone therapy for menopause, that our goal is to raise your hormone levels back up to that baseline. Um, so there's no baseline level that is the level for everyone. And in fact, reproductive hormones can vary just from cycle to cycle in the same woman. So if you were having your hormones tested, say because you wanted to do an egg retrieval cycle for fertility reasons, it's not that important. They will often test your hormones like daily. And if you're doing 2 cycles, they'll test your hormones very frequently in those 2 cycles. And you can see differences in the same woman from one cycle to the next. So the best way to know that your reproductive function is good right now is regular periods, assuming you're not on on hormonal contraception. So regular periods in someone not on a birth control pill or an IUD is the best way to know that your reproductive function is what we want it to be. Um, The best reason to start on hormone therapy is because you're having symptoms. And the way to know that you're on the right dose of hormone is because those symptoms are managed. And so it's not that we want to give you enough estrogen and progesterone to raise your levels back to this perceived baseline. There is no baseline. The goal of giving you hormone therapy is just to treat your symptoms. And in fact, that misconception is why the Menopause Society decided to change the name. So we used to call it HRT, or hormone replacement therapy. Um, we're not really replacing estrogen. We're giving you back a small amount of estrogen at an even level to manage your symptoms. And so I think that distinction is feels a little semantic, but it's actually really important, because it's not like, oh, your estrogen used to be 30. I'm just throwing a number out there. Your estrogen used to be 30. Now your estrogen is 5. And so we're going to give you estradiol and a dose to get your estrogen back to 30. That's not how we give hormone therapy. And so the short answer is no. There is not necessarily an indication, if you are healthy, to get a baseline hormone level checked. Now, there's lots of reasons why we do check reproductive hormones. If your periods are irregular, or if you are having symptoms of perimenopause or menopause at a time when you when we wouldn't expect you to, so before the ages of 45 or after the ages of 60. These are all real, legitimate reasons for checking hormones. I mentioned another one earlier, which is to manage an egg retrieval cycle, whether that's for egg freezing or IVF. We often will, check reproductive hormones. And sometimes there's utility in, among women who maybe don't get a period because they have an IUD or because they've had a hysterectomy. It can be helpful for us to get a sense of where your hormones are, so that we can manage um, for perimenopause. So, for example, I have a patient, she's in her early 40s. She was having a lot of night sweats. Um, but she has an IUD and she doesn't have a period, which is great. And so we couldn't tell if her periods were becoming irregular, if her night sweats were aligning with certain points in her cycle. Um, or if maybe her night sweats were from something completely different. She has prediabetes and can have symptoms related to how her body is processing carbohydrates. And so we checked her reproductive hormones, because what we wanted to understand was, were her symptoms from perimenopause, or were her symptoms maybe blood sugar related? And so we checked her reproductive hormones. They showed that she was not perimenopausal. And so we were able to say, oh, these symptoms are probably blood sugar related, and manage them that way. And actually, that was super effective. So there are good reasons to check hormones, but just to get a baseline is sort of not a helpful metric. Um, and then the other question that I got sort of in advance was about preferred dosing for hormone therapy. And the question was, I have premature ovarian insufficiency. What is the preferred dose for hormone therapy? Um, and this this is a little bit of a follow-on to the last question, which is sort of like, how much estrogen is the right amount of estrogen to get benefit? Um, and there's not really a preferred dose. The goal is to manage symptoms. So, if you're having symptoms, we want to give you enough estrogen and progesterone to adequately manage those symptoms and protect your uterine lining. And so different doctors do it differently. For a long time, we were told, if you must take hormone therapy, start on the very lowest dose, use the lowest dose that controls symptoms. that philosophy in the last 5 years or so has really changed. Um, I actually typically, when it's not in shortage, as I mentioned earlier, I actually typically like to start with a middle of the road dose because more often than not, that is a dose that works well for women. And then if it feels like it's too much, we can go down a dose. And if it feels like it's too little, we can go up a dose. But I really start with the middle of the road dose for most people taking hormone therapy, and then adjust accordingly. So like I said, there's not a level that we have to get to, even in women with premature ovarian insufficiency, which is menopause before age 40, where we do recommend hormone therapy for everyone, whether they're having symptoms or not. Um, there's not a specific dose that we recommend. There's not a dose that's been shown to reduce some of the risks associated with premature ovarian insufficiency. And so we don't really dose that way um ever, really. So there's not a preferred dose. Different practitioners will have different styles about how they or how they kind of approach getting someone started on hormone therapy. My personal style is I start with the middle of the road dose and then adjust up or down, unless there's a reason to really try and have someone on an extremely low dose. um, so yeah, I hope that's helpful. um, I've really enjoyed getting all of your questions and answering all your questions today. We did a lot of talking about drug manufacturing and the FDA. But sometimes those are the questions that we have. Hopefully, the manufacturers that manufacture the estradiol patch will be able to ramp up their production as quickly as possible so that you all can find your estrogen patches. Because I know that's really stressful when you can't find a medication that you rely on to feel well. Um, I will be back, I think on March 9th, but obviously I'll send an invitation out. And I will be having a guest. We will be talking about um, perimenopause and managing the symptoms of perimenopause in the setting of neurodivergence. My guest has some really unique and interesting ways of helping people with things like ADHD symptoms and brain fog in the perimenopausal years so that you can keep feeling like you're achieving your goals and doing all the things that you want to do. Um, I think that this probably will be a useful conversation for everyone, not just for women who maybe are neurodivergent, because everyone can experience some of the brain fog and lack of focus that is so typical of ADHD in particular. There's also a lot of women out there who maybe have not yet been diagnosed with ADHD because they don't have classic symptoms. And so I think this will be a conversation that can be useful for everyone and not just those who have been diagnosed um, with something like that. So I will be sending more details out about that probably next week, but you can start sending in your questions now. You can send them in a DM on Substack, or you can send them to ask at thesavvypatient.com, and we'll try to address all of those questions. And then, of course, in the second half of March, I'll do another AMA, um, and we'll tackle more of your questions there. um, Thanks so much for joining me. If you weren't able to join us today, I hope you enjoyed the video, and I'll see you all again soon. Bye bye.